Okay, retinal degenerations part 2. Good. All right, what I want you to do is describe what you're seeing.
So fundus photo of the right eye.
Good.
And so looking at the disc, it looks relatively normal, maybe some temporal pallor, but rim thickness looks okay. Looking at the vessels, the contour and appearance looks normal. So the macula, it looks like there's some type of hypo, I don't know what you would call that, kind of hypo coloring, I don't know.
All right,
of the
changing color, and you're talking about inferior to the fovea.
Exactly.
Okay, good. Anything
and then
else?
Peripherally, there's these kind of patchy, hyperpigmented areas.
Good, good.
And then maybe some, I'm looking again, these kind of deeper vessels kind of look
emanating from the disc.
Yeah.
Good. You picked up on all the things that I want you to see. So, and you also bring up a good point. When I'm looking at a photo, I mean, I know what this is. I've seen it like 30 times. But when I'm seeing a new photo, it helps to have like a routine, a checklist that you go through. So I'll say color fundus photo of the right eye, clear media, so vitreous, whatever. Mm-hmm. The disc looks, good margins, nice coloration to it, no pallor. The blood vessels, there's normal tortuosity, no attenuation, there's no AV crossing change, things like that. And then the background coloration looks a little bit off, but you wouldn't know that unless you've seen this a few times or seen the next photo I'm about to show you. But you mentioned these kind of radiating little dark streaks coming out from the disc that almost look like blood vessels. Mm-hmm. And you mentioned a little bit of some kind of almost yellowish coloration going inferior to the fovea. And you mentioned these little tiny dots out here temporally. So I'm going to show you the next image. These little dots, if I could convince you, are actually yellow dots, and the reddish portion, more temporal, is normal.
Yeah, okay.
So what you're seeing is this kind of, I wouldn't say pale yellow, but this kind of orangish color. And this particular sort of transition zone between the orangish color and the reddish color has a very specific name for a person with this syndrome. It's in French, and it's peau d'orange. Good. So it's that, orange peel appearance. This is a montage. So this patient has angioid streaks. That's what you were seeing emanating from the disc. And what do angioid streaks put you at risk for?
Angioid streaks.
Well, first of all, do you have a different
detachment?
Not retinal detachment. Do you know what kinds of disease entities will cause an angioid streak?
The only thing that's coming to mind is pseudoxanthoma elastica.
That's exactly right, and that's probably what this patient has. You don't get the peau d'orange with other entities necessarily. I say that, I'm not 100% certain on that, but that's my impression, and I don't have a lot of patients with angioid streaks. There's a mnemonic, right, for causes of angioid streaks, and it's called PEPSI. You ever heard of it? Did we talk about it last week? 2 weeks ago?
I've heard of the PEPSI mnemonic.
So one of the P's is pseudoxanthoma elasticum, and then the E is Ehlers-Danlos. The next P is Paget's disease. Then S for sickle or sickling hemoglobinopathies, and the I is for idiopathic. Actually, older folks can get these little cracks in Brooks membrane and can get angioid streaks. So there's 2 things. Since Aaron's here, Aaron, can you give me an idea of a couple things that angioid streaks can lead to that could be bad for an eye?
Choroidal neovascularization.
Right, CNV. And what's the other one? I'll give you another picture.
Choroidal rupture.
Right, so they actually will bleed, so you have to tell these folks to not involve themselves in multiple, ninjutsu type sports. And then,
Ninjutsu.
I don't know, what do people do now?
Awesome.
CrossFit, you probably should do CrossFit.
Right, exactly.
They should wear eye protection, and that's what happened with this patient. They came in, this is obviously the fellow eye, and that eye got hit I don't even remember, I don't know what the name of the kind of blood trauma was.
Picture of.
Unless it's your eye, right? But yeah, but that brings up another good point. If you see a little hemorrhage, you don't always know if it's a CNV or if it's just a little bit of trauma or just some spontaneous crack. Mm-hmm. So what kind of study do you want to get to differentiate how you're going to treat them and manage them? Right, you want to get a fluorescein, because then if it's a CNV, you're going to see this leakage, this hyperfluorescence that expands and goes beyond its original borders. Thanks, Aaron. And so And actually up here, it's kind of whitish. That's probably, it's either commotio or old blood, and I don't know which. So if it's commotio, that fits with this whole trauma picture. Let's see, there's the mnemonic, pseudoxanthoma, Ehlers-Danlos, Paget, sickle cell, idiopathic. So I have a patient, I don't think he's in here, but I thought he had AMD for a while. He had a very tiny baby, angioid streaks. You might have seen him a couple weeks ago. And so I treated him. Unfortunately, the treatment was the same. He had a CNV, we treated him with anti-VEGF. Eventually sent him for genetic testing. He had ABCC6 mutation, which puts you at increased risk for what else? Early onset arterial disease, peripheral arterial disease, heart disease. He'd actually already had a fem-pop bypass before he came to my clinic when I first saw him 3 or 4 years ago. So paraneoplastic retinopathies, again, we're still in the category of systemic diseases associated with retinal findings. CAR and MAR. There's not much to say about this photo, right? You first look at it and you're like, something's a little bit off. But again, color fundus photograph, left eye. Maybe some haziness to the view. I don't know if that's vitritis or maybe a little mild cataract, but just a little bit hazy. Might just be photography, really. You could see some more prominent choroidal vessels. Maybe there's some RPE atrophy. And the most prominent finding, I think, is some vascular attenuation, both veins and arteries, particularly arteries, though, especially this inferior temporal or arcade. And maybe there's some mild pallor, temporal pallor, I'm not sure. But this is kind of, the CAR and MAR patients, you really have to do additional testing to make the diagnosis. So I send their blood samples out to Oregon and look for antibodies. And even then, it's not always straightforward because a certain percentage of the normal population is going to have them. The older you get, the more likely you are to have auto anti-retinal antibodies. But what you need to know about CAR, so recoverin was sort of one of the first proteins or antigens to be associated with it. Others are these alpha enolase, arrestin, transducin, neurofilament. You kind of at some point need to memorize this list before you take OCAPs because these do occasionally come up. On occasion, retinal disease may precede clinical recognition of the cancer. So I've got a couple of patients in my clinic right now that have what I call autoimmune retinopathy. They had some atypical findings. I sent off their blood samples. You might have seen them with me. They came back positive for 5 or 6 antibodies each of them, and they also had staining on the not the Western blot, one of the other tests that they did, and so now I'm initiating this big systemic cancer workup. And I haven't found anything in either one of them. So, it's a little bit frustrating for me and the patients. Their symptoms, one of them's got really bad nyctalopia, but he says, no, I don't have night blindness. When I walk into my house during the daytime, I have to turn on a flashlight to see what I want to see. The other one has bright and incessant flashing lights, photopsia. So treatment is terrible. The options aren't that great. Steroids, intravitreal, periocular, etc., systemic. Plasmapheresis, people try all kinds of stuff with very mixed results. Okay, so patients with CAR due to anti-recoverin have a very specific pattern that they talk about in the book. Rapidly progressive loss of peripheral vision, sometimes central, have photopsias and ring scotoma. Goldman, you got to do visual fields on these people, show dramatic field loss over a few months. ERG is usually, either classically with melanoma-associated retinopathy, they've got that negative ERG. CAR isn't necessarily as predictable, but you get reduced A and B waves. And people with, if you really want bonus points on OCAPs, people with CAR due to anti-enolase as opposed to anti-recoverin tend to have cone dysfunction that predominates rather than rod. This is more of a rod kind of thing. So anyway, MAR, I think the main thing I ever learned about it was the negative ERG. And at one point I knew that they had antibodies against retinal bipolar cells. And that was all I ever needed to know. What's an easy way to think of albinism? Like if somebody says, "What's albinism?" One of your patients.
Like lack of pigment.
Right. Yeah, it's just as simple as that. So you've heard these two terms, right? Albinoidism. Do you know the difference?
Heard about it.
Okay, good. Might be helpful. I actually don't like this particular section of the lecture. Both of them are photophobic. Both of them get iris transillumination. Both of them have hypopigmented fundi. Albinoidism is kind of a less severe form of albinism, and the distinguishing feature is nystagmus. Albinism is going to have nystagmus. Albinoidism is not. That's a really old animation. Then you could break up albinism into ocular versus oculocutaneous, right? The reason I put the asterisk there, I believe, is because even though the skin and hair have normal pigmentation, when you look at their pathology, if you look at them under the microscope, they actually are a little bit decreased. And these are usually X-linked. This is kind of variably tested. And then female carriers have these iris transillumination defects, and then they get this kind of pigment mosaicism, so these gray patches out in their retina. I've never liked this categorization, but it's usually autosomal recessive, and then you can break them down in tyrosinase positive and tyrosinase negative. More commonly these days, we're just breaking them down not by the enzymes, but by their genetic mutation, and that's not as testable. But what you do need to know is this is an old slide that was like scanned in or something from Bill Benson, is these two subtypes, right, of albinism. One of them has a bleeding diathesis, Hermansky-Pudlak, and then one has infection issues, Shidiak-Higashi. So you just got to think about these things. But I think both of them are from Puerto Rico. Or no, just Hermansky-Pudlak's Puerto Rico. Shidiak-Higashi may not be specific to a region. So this is a patient that has a hypopigmented fundus, right? Mm-hmm. Look around, you see very prominent choroidal vessels. But then if you look at the other eye, it's pigmented. So this is obviously not albinism or albinoidism, but this is a patient that had this as well. He had a blue iris and a brown iris, and I guess nobody ever made much of it. So anyway, I thought it was really interesting. I asked him if he ever had like a white forelock. He said no, but he said when he grows his goatee out, his soul patch is white. So do you know what I'm thinking of? Waardenburg, right? He didn't have. That's right. You're coming back. All right, we'll take a break after this to talk about the patient. Hypertelorism, cochlear deafness, white forelock, heterochromia iridis, and this RPE pigment disturbance, which is what it's listed as in the book, might actually mean that one fundus is really hypopigmented and one's normal. Thought that was interesting. He also had a cataract on the side that was abnormal. Now this is more your normal albinism type picture. And then they also get these very interesting, one of the residents just presented a couple of our patients not too long ago. It wasn't one of you guys. But they just get the loss of that normal foveal contour. And people have staged it out based on which layers are present in the fovea that shouldn't be. I spent a lot of time memorizing these as a resident and never found it to be helpful.
I don't either.
The Batten disease, they break them down into 4 groups based on their age. If you ever said this when you're talking about your bullseye maculopathy differential, you're going to get some kudos for it, but you definitely want to get like the Stargardts and the Plaquenil first. So anyway, I don't know if you'll ever diagnose somebody with a neuronal ceroid lipofuscinosis, but there's usually mental retardation, progressive dementia. So this part of the lecture would be better given by somebody else. But they break them down into 4 types, and for whatever reason, I spent the time memorizing all these names. Lake Kavanaugh, Spielmeyer, Voigt, Batten, and really never got any bang for that buck. So this one's a little more testable. A-beta lipoproteinemia, autosomal recessive. You get these fat-soluble vitamin deficiencies. I think they're the ones that have steatorrhea because they just poop out their fat. Yeah. And anyway, so they get vision loss, night blindness. Now we switched over to something else. I just totally changed subject. So they get a pigmentary retinopathy. They get acanthocytosis. This is from medical school. I don't really remember anymore. But anyway, that's all you need to know about it. So hypovitaminosis A, and then we're done. Most commonly seen after gastric bypass. That's why we talked about Crohn's disease. And night blindness, vision loss. I've seen a couple of people with it last time when I was in Burundi in April, and neither one of them had any of those little tiny white dots that they supposedly can get or RPE changes peripherally. But they both were severely malnourished moms that were kind of giving their food preferentially to their kids who were also malnourished. By the way, if you didn't hear, Global Health Index this year said Burundi was the hungriest country in the world based on a number of factors. So very, very poor. It's no surprise when you go there and everybody's wearing the same shirt every day that you work with them from the staff, and they're the ones who are even better off. These are those little dots. I searched all over for a good picture. There's probably some good pictures out there that I couldn't find. A few more of those little dots. And those go away with treatment. So we'll stop there. and talk about some patients.